Good afternoon, everyone, and welcome to this last talk in the afternoon session. Thank you, Drs. Thompson and Ware, for terrific presentations that are setting the stage for this last talk, and thank you to the organizers for the invitation to talk about something that's near and dear to my heart. I'm Sujit Sheth. I run the Thalassemia program at Weill Cornell Medicine, and that is obviously going to be the focus of what we talk about for the next 20 minutes or so. These are my disclosures. And so without further ado, the thalassemias are really a group of disorders that have a wide spectrum of severity. So you have individuals who have mild disease, very mild anemia at the low end of normal, and transfusions are very rarely required. These are individuals usually with the trait. Then you have an intermediate severity of disease, which we call non-transfusion dependent thalassemia, where the anemia is moderate, and they may require occasional transfusions. And then you have the most severe type, which is the transfusion dependent thalassemia patients who require transfusions lifelong. And in the slide, you can see some of the genotypes that are associated with those different severities. Even though we are talking about thalassemia in a session that is titled benign hematology, I rather prefer the term non-malignant hematology because thalassemia is not really a benign disorder. You can have a lot of complications and it can reduce your life expectancy as well. So this is just a very quick overview of normal erythropoiesis. You can see that there are two main stages: early stage, which is mostly erythroid proliferation, that is characterized by the proliferation of progenitor cells promoted by erythropoietin, and late stage erythropoiesis, which includes differentiation and maturation, where you have differentiation of the erythroblasts, maturation to reticulocytes, and then into red blood cells. It's somewhere in the middle that hemoglobin starts to be produced as a result of expression of the globin genes, and that then fills up the red blood cells and they come out into the circulation. It's important to keep in mind that the late stage is regulated by members of the TGF-beta superfamily of ligands, and this is relevant, and we'll talk about that when we talk about some of the newer therapies later on in the presentation. What happens in thalassemia, and more so in beta thalassemia than in alpha thalassemia, is that there is a significant amount of maturational arrest. And so even though erythroid proliferation is proceeding normally, or in fact at a heightened level, differentiation and maturation is impaired. And as a result of that, there is apoptosis of the precursors in the bone marrow itself, a maturational arrest, and accumulation of those proteins that are members of the TGF-beta superfamily of ligands that prevent this maturation from occurring. And as a result of that, you'll see that the hemoglobin is not formed normally, and therefore the individual becomes significantly anemic. So to summarize, the features of ineffective erythropoiesis, which result primarily because there's an imbalance between alpha and beta chain production in thalassemias. This results in impaired erythroid maturation, erythroid precursor maturation, a formation of toxic hemichromes within these precursors, precipitation of the unpaired alpha globin chains or beta globin chains, depending on what abnormality you have, apoptosis of those precursors in the marrow itself. The cells that do come out are also somewhat abnormal, and you have a reduction in red cell survival, all of which results in anemia and increased erythropoietic drive, so increased EPO secretion from the kidneys, which stimulates extramedullary sites as well, where you might have rests of erythropoietic cells. So extramedullary hematopoiesis and dysregulation of iron metabolism as well, with increased iron absorption from the gut as a result of this ineffective erythropoiesis. So this is a very complicated slide. I'm going to very quickly walk you through this. So there's a relative excess of either alpha or beta globin chains, depending on what kind of thalassemia you have. As we mentioned, there's apoptosis of late erythroid precursors in the bone marrow, resulting in ineffective erythropoiesis. This results in the extramedullary hematopoiesis and expansion of the bone marrow as a result of EPO secretion. Hepatosplenomegaly results, you can have little nodules or nubbins of erythroid marrow that come out of the vertebral bodies that can actually cause compression on the spinal nerves or even the spinal cord. And so back pain in these individuals is very, very serious, has to be taken very seriously. And then because of expansion of the bone marrow, there's significant bone disease, changes in the skull bones that result in abnormal facies, and then osteopenia and fractures as a result of thinning of the cortices of the bone because of the massive hyperplasia of the bone marrow itself. There's damage to the RBCs. Hemolysis results because of that. And the central complication is anemia as a result of the ineffective erythropoiesis as well as the hemolysis. This might lead to increased iron absorption from the gut, as well as a need for red cell transfusions, which can be variable depending on how much hemoglobin you actually make, how many red blood cells, effective red blood cells you actually make. Both the red cell transfusions and the increased absorption result in iron overload. This iron overload affects the liver, which can cause fibrosis, cirrhosis, and hepatocellular carcinoma. It can affect the heart, affecting both contractile function as well as electrical function, so heart failure or arrhythmias may result. And it can deposit in the endocrine organs, including the pituitary, thyroid, testes, ovaries, and endocrine, pancreas, all of which can result in complications that are from the iron overload itself. In addition, particularly in individuals who have non-transfusion dependent thalassemia and have a significant proportion of abnormal cells in the circulation, there's vascular disease and a hypercoagulable state that results. This can lead to thrombosis in the venous system, as well as leg ulcers from poor perfusion, silent cerebral infarcts, and the development of pulmonary hypertension, all of which can have significant morbidity and mortality as well. And then obviously the symptoms from anemia, if the individual is not transfused, which includes pallor, fatigue, exercise intolerance, in children, poor growth and development, and overall an impaired quality of life. So definitely not a benign condition. We'll talk a little bit about the current management of beta thalassemia, and we'll divide this up into transfusion dependent and non-transfusion dependent. Individuals with transfusion-dependent thalassemia receive regular blood transfusions approximately every 2, 3, or 4 weeks. The goal is to maintain a pre-transfusion hemoglobin in the 9.5 to 10.5 grams range. This suppresses ineffective erythropoiesis effectively, as well as provides enough hemoglobin for growth and development in children, but also for normal activities in adults. We will talk about luspatercept later on, but this has now become part and parcel of how we treat transfusion-dependent thalassemia. And as a result of the iron overload, to prevent iron overload-related complications, we have to give iron chelation therapy, the goal of which is to maintain a liver iron concentration of 2 to 5, in the range of 2 to 5 milligrams per gram dry weight. This is obviously measured by MRI. We don't do biopsies really anymore. As well as maintaining your cardiac T2 star, also on MRI, greater than 20 to 25 milliseconds. This is the ideal range we want to keep these individuals in and prevent them from having complications in those two organs, as well as prevent them from having systemic iron overload, which may cause endocrinopathies and other complications as well. And then you have to really be very diligent in terms of monitoring and managing the complications should they actually occur. So serial MRIs, endocrine evaluations, bone density evaluations, follow-up with cardiology and endocrinology is all part of the management of thalassemia. Stem cell transplantation is the only available curative therapy currently. The best results are when you have a matched related donor with myeloablative conditioning, and this results in a greater than 90% event-free survival. And recent studies have shown almost 100% overall survival as well. Transplants with unrelated donors, haploidentical donors, or reduced intensity conditioning are all in trials. The results of those are getting better, but are still not that great, and so not really ready for prime time as of yet. Non-transfusion dependent thalassemia patients may require transfusions occasionally. Sometimes they sort of move along the spectrum and go from being transfusion independent or non-transfusion dependent to being transfusion dependent. And this is really dictated by the occurrence of complications such as silent strokes and pulmonary hypertension or spinal nodules of erythropoietic tissue. And that might convert somebody who is non-transfusion dependent into a transfusion dependent thalassemia patient. As I mentioned, even in the absence of transfusions, these individuals can become iron overloaded, and so serial MRIs and iron chelation therapy to manage their iron overload are mainstays of treatment as well. Hydroxyurea, decitabine, and butyrate have all been used to try and modify erythropoiesis in these individuals. Results are variable and in general not very good, and so these are not really mainstays of therapy for non-transfusion dependent thalassemia. Obviously, you have to continue monitoring for complications, both of the disease itself as well as for iron overload. And stem cell transplantation has been used in non-transfusion dependent thalassemia also to cure them, usually reserved for the more severe disease individuals who are requiring more intermittent transfusions or who show signs of progressing from the complication standpoint to requiring transfusions regularly as well. So to summarize again, complications can be broken down based on transfusion dependent versus non-transfusion dependent. Amongst the transfusion dependent patients, the complications are almost all related to iron overload. So you can see thyroid disease, parathyroid disease, cardiac siderosis, hepatic disease, diabetes, hypogonadism, and osteoporosis. In addition, individuals may have transfusion reactions and may also develop alloimmunization. Amongst the non-transfusion dependent patients, most of the complications are related to the disease itself. And most of these are related to a vasculopathy that results in these patients from the abnormal red blood cells that are coming out of the bone marrow. Silent cerebral ischemia is not uncommon. Pulmonary hypertension and right-sided heart failure, the presence of extramedullary hematopoietic pseudotumors with complications including spinal compression, hepatic fibrosis, cirrhosis, and cancer may develop as well. Gallstones from the increased hemolysis, splenomegaly from both ineffective erythropoiesis and extramedullary hematopoiesis, as well as from hypersplenism. Again, osteoporosis, venous thrombosis, and leg ulcers. So these are all complications that can occur that we want to really try and prevent. Survival without treatment in beta-0 thalassemia, so the individuals who make no beta globin at all, the natural history of this disease is death within the first 2 to 5 years from heart failure because of the severe anemia. In non-beta-0 thalassemia individuals, there's a variable spectrum of severity and therefore variable complications and a variable mortality rate as well. With treatment, we have improving survival, as you can see from this Kaplan-Meier curve on the left-hand side of the slide. And you can see that based on birth cohort, patients who were born in the 60s didn't really live much into their second decade or third decade of life. But those who were born later have had better life expectancies. And I think it's fair to say that patients born after the year 2000, particularly in the era of oral chelation and better monitoring of iron overload, should have near normal life expectancies. Of course, these older individuals do have significant morbidity, but the incidence of those morbidities is actually decreasing for sure. We've made a lot of advances in therapy over the last 2 or 3 decades. The safety of the blood supply has increased tremendously, and the risk of transmitting diseases like HIV and hepatitis has gone down very significantly to almost zero. There is a reduction in the incidence of alloimmunization as a result of better phenotyping of the blood that we give these individuals. We have oral iron chelation. We have better ways of monitoring iron overload and individually tailoring the treatment regimen. We have improved treatment of hepatitis and HIV for those individuals who did contract it. And outcomes for stem cell transplantation have also improved dramatically over the last 30 or 40 years. Despite this, however, there are still several unmet needs for these individuals. As I mentioned, not all individuals with thalassemia have a matched sibling donor and therefore are not eligible for a stem cell transplant and therefore not eligible for a cure. But as you heard from Dr. Thompson when she talked about gene therapy, that is certainly something that is being addressed by gene therapy. And so the possibility for these individuals without matched sibling donors is going to suddenly get much, much better as well. Having a means of ameliorating ineffective erythropoiesis would go a long way in reducing or eliminating transfusion requirements, in turn reducing iron overload and therefore both from the gut as well as from transfusion, and therefore preventing iron overload and its complications. Reducing bone disease is something that we really want to try and do more effectively, and then improving the overall quality of life. So thalassemia will remain a cumbersome disease because you have to go in for your transfusions every 2, 3, or 4 weeks. You have to take a medication every day. You have to go in for a lot of monitoring, and you have to go in for a lot of other visits to other specialists like endocrinologists and cardiologists as well. So neotherapies for beta thalassemia can be summarized in this slide. And I'm not going to talk about stem cell transplant or gene therapy because that's something that you've already heard about. I'm going to focus mostly on this area here and this area here. So essentially, you have ways of affecting ineffective erythropoiesis. We won't talk about the JAK2 inhibitors because that trial was not did not have a positive outcome. We'll talk mostly about luspatercept. And I will mention the pyruvate kinase activators and the phosphodiesterase 9 inhibitors right now as being in early stages of development. The phase 1 trials and phase 1/2 trials are underway now. So it's still very early to give you much information about these. But we'll focus on luspatercept, which has been approved for use as well. Trials are also underway with the mini hepcidins and the hepcidin analogs. These have not been particularly successful to date, but there's still one trial that's ongoing that I will not mention in much detail because we don't have results from that as of yet. So let's focus on luspatercept very quickly. This is a recombinant fusion protein containing a modified extracellular domain of the activin receptor 2B. It binds to GDF11 and other members of the TGF-beta superfamily, and this inhibits SMAD2/3 signaling, promoting erythroid differentiation and maturation. There's early animal data, there's phase 1 and phase 2 trials which have been published, so I won't spend much time on that. And this once again shows that schematic of normal erythropoiesis and ineffective erythropoiesis, and this is where the TGF-beta ligands will act by blocking differentiation. So if you can remove the TGF-beta ligands, then you will actually be able to promote red cell differentiation and maturation. So the BELIEVE trial of luspatercept, the primary endpoint was to see an erythroid response in weeks 13 to 24. Which would result in a 33% or greater reduction in transfusion burden over that pre-specified time period. And then there were additional secondary endpoints and additional endpoints which are listed here, which I won't go into detail for. Suffice it to say that the primary endpoint was met. There was a statistically significant difference in reduction in transfusion requirement between patients on the luspatercept arm. 21.4% of patients had a 33% reduction or greater, and 5% of patients in the placebo arm. And then the secondary endpoints were also met with statistical significance when the data was analyzed carefully. So basically, the summary of the BELIEVE trial, it met its primary endpoint, demonstrating statistically significant reduction in transfusion burden of 33% or greater. It met its secondary endpoints as well. And it was generally well tolerated with very few significant or serious side effects. And therefore, it was approved for use in November of last year. Anticipated other therapies for thalassemia include luspatercept for non-transfusion dependent patients, as well as children. Right now, it's only approved for adults. These are in trials. Gene therapy, both gene addition and editing, which Dr. Thompson has already talked about, which are in trials as well. And then I mentioned the other ones, the pyruvate kinase activators, hepcidin analogs, and PDE9 inhibitors as well. Just very briefly to talk about the novel therapies for other inherited anemias that are in the pipeline. So pyruvate kinase deficiency of mitapivat, as well as FT4202. These are in trials as well. And then phase 1 gene therapy trials for pyruvate kinase deficiency are also underway. Diamond-Blackfan anemia, we have a trial of sotatercept, which is also a modifier of the TGF-beta superfamily of ligands. And then gene therapy for Fanconi anemia is in phase 2 trials currently as well. So that's a sort of overview of the thalassemias as well as the some of the other inherited anemias. And I'm going to stop there and anticipate questions. I thank the organizers again. Thank you for your attention, and let's take some questions.